the thing I will say about this talk, hold on to your hats, and I apologize for all kinds of rough spots. This is a brand new talk. Vivek likes to challenge us. And this year, he asked us to talk about the Achilles heel of digital behavior change. And it turns out there are two, and Angela has talked about one of them, keeping people engaged. And I get to talk about the other one, which is maintaining behavior change, which is an Achilles heel for all kinds of behavior change, including digital. So off to the races. I want to start by asking people a question. And my question is, I really would like to hear from you about whether you think that people can improve their health by changing their behavior. I've been in this field for a long time, and I hear all kinds of answers to that question. So would you share with me your thoughts about whether people can change their health by changing their behavior? I'll look for hands, or I'll see them. I suppose I should start by asking you, what are you doing here if you don't think it can? But that's really a teaser, because there's room for many, many mixed opinions. CJ Lou, I'm going to misinterpret that you were raising your hand then when you were adjusting your screen.
I thought I saw Ravi also had raised his hands.
Okay, great. I guess I can't see all of the folks at one time. Yeah, Ravi, what do you think? And you're muted.
I didn't raise my hand, but I can talk.
Oh.
Good. I'm sure everybody has an opinion on this.
It's an interesting question in the sense, like, yes, it is possible. We just haven't figured out the golden bullet in the scenario. Like, how do we get people to do it, right? So at least for me personally, that's why I'm here, trying to figure out better ways of helping people do behavior change.
Okay. Aaron, were you going to say something? I saw you
Sure.
come off of mute.
I guess going along with, I'm a pediatric surgeon. I do a lot of bariatric surgery. I'm the only one in the state that does adolescent bariatric surgery. And we can certainly change people's behavior by removing part of their stomach, right? So that's a behavior change that occurs. It's a hormonal process. It's obviously a very drastic thing to do, but you can change people's behavior by doing that.
Okay, that's fair. And it's great to remind us we are in the health arena, and that's a very important perspective. What about those of you who change your behavior every morning? We're going to have a healthy diet today with lots of exercise. Isn't that behavior change? Well, why doesn't it count? It does. It often just doesn't last very long. But we can do it. It's like the people who say, yeah, of course I can quit smoking. I've done it 65 times. It's just, I go back. Other thoughts? Anybody think we really can't change our behavior?
I think we can. And I'm Phyllis.
I
think
that not Alyssa, right? Okay.
not Alyssa. I really hope, I would really wish I could change it to not Alyssa, really Phyllis, but I can't adjust the name on here. But I think we can. I work with people who have substance use disorders, and absolutely their health can improve if they don't have harmful substance use, right? So so to answer your question, I absolutely believe that.
Okay. There's got to be somebody here who thinks that you can't change behavior. It's Aaron. You are the pediatric surgeon. if you're not using surgical techniques, do you think that people can change their diet and physical activity so that they can lose a meaningful amount of weight?
Well, we all know what all of the studies show, which is that it's diet and exercise alone are very difficult. In large population health-based studies to show meaningful change. Although, certainly individuals do it on a regular basis. I mean, we all know people who've stuck to an exercise program and a diet program and lost a meaningful amount of weight. I think that the systems are just so complicated, and so the individual system, not counting the system of multiple people, is very difficult, and impacting and changing one person's behavior is, it's a multifactorial complex process, in my opinion.
Mm-hmm. Not to mention the toxic environment, which keeps financially incentivizing companies that make it very hard for us to control what we're ingesting. When you think about people's preferences, so for many of the risk behaviors that we'll talk about, there are surgical alternatives, there are other kinds of technical or device interventions, there's pharmacotherapy, and there's behavior change intervention. What do you think people's preferences are? If you had to place a bet, what do you think people would prefer to have?
Probably behavior change, if I had to guess.
I think it's true. I think that has been a long-standing finding. And if the first step in making a change is having it be something that you feel you'd like to do, you feel comfortable with doing, that's got to factor in there someplace. So, okay, all right. I think we have heard a spectrum of opinion, and I have to say, having worked in this area for quite a number of years, it's been my experience that when I first began working in this area, I encountered many physicians, particularly oncologists, some cardiologists, who said, look, you can't change people's behavior. You just can't do it. And I thought that was very interesting. I hear it a little bit less now, but it's not gone. I still hear from many of particularly the specialist physicians I work with, a whole lot of pessimism about whether it is possible to change behavior. So I'm going to pull back up the slides now, if I can. Oops. Got the slides up, they're just not advancing. Let's see. Here we go. Stop again and start. Well, that is pretty awful. If I do this manually like so, can you now see a slide that says maintenance of behavior change, or are you still seeing the original one?
No, we can see that.
Oh, good. Okay. I will just do it manually, and that's how we'll manage. Okay. So I do want to put in perspective the fact that we have really made a lot of progress in the arena of health behavior change and even maintenance. We now, for some of the really tough behaviors to change, like smoking and overeating, physical inactivity that lead to obesity, probably we can say that about between 10 and 40% can either quit smoking or achieve meaningful weight loss up to 6 months with behavioral treatment without pharmacotherapy or meds, that is a huge amount of progress. And I will put it in the perspective that I did a study that was published in JAMA Internal Medicine in 2012. To me, always puts this into perspective. We were changing 2 unhealthy diet behaviors and 2 unhealthy physical and activity behaviors. So excess sedentary time, insufficient moderate vigorous physical activity, insufficient fruit and vegetable intake, too high saturated fat intake. And at that time, there was enough skepticism among our medical audience that people could change behavior at all, that we paid people $200 to make major changes for 3 weeks. And that was considered reasonable because nobody was sure that folks could do it. The interesting thing that I learned from that study was that after the 3 weeks, we stopped paying folks, and about 50% of them maintained their gains for 6 months, even though they didn't have to. So I found that very interesting. They seemed to think, gee, it was, once they had done it, they had put in the effort, and now they were going to keep it up. So I just found that really fascinating. I think another thing we need to think about with behavior change is, even when we're talking about medical treatments, a big part of medical treatment has to do with adhering to the medical treatment. And we know that about 50% of prescribed meds are not taken. So there's definitely room for improvement there. But I think it's also worth remembering, as we were just reminded, that we are in a medical arena. We are talking about health and disease. And in medical clinical trials, behavior change and even biomarker change are considered to be intermediate outcomes in clinical trials. Really, the interest is in preventing disease onset, preventing events like heart attacks, and also reducing care utilization. Those are things that take a long time. You need long trials to see those things. So basically, how many of us work is that we assume you have to start that train with behavior change if you're going to wind up with some kind of a meaningful outcome. Now, let me see. Let me try again to see if I can pull up this slide. Nope. Oh, here we go. Okay, now let's go to the problem that I'm going to mostly focus on, which is obesity. As we've already gone there, this is the problem that is, it's extremely prevalent. It's really doing great damage to the finances of our healthcare system. At this point, about 42% of adults in the US have obesity, and it's not only a US problem, it's a global problem. About 20% of children and adolescents do. And this is very sad. We're starting to see a diabetes onset, cardiovascular disease onset, even in youth. If we combine overweight and obesity, about 71% of adults have that. And why does this matter? Because obesity is just a major risk factor for the vast majority of prevalent chronic diseases, cardiovascular disease, diabetes, many cancers, arthritis, and so forth. How do we do with treating it? And I'm going to focus mostly on behavioral treatment. I will touch on pharmacotherapy. I'll just briefly mention bariatrics because it's already been brought up. Maximum weight loss when we're doing behavioral treatment happens at 6 months. We usually can't exceed that. It's rare for somebody to keep going on and not plateauing beyond 6 months. About 20% of people maintain 5% weight loss up to 2 years. How meaningful is 5%? Well, the public health standard is that 5% is meaningful. It gives you detectable health benefits. 7% has been the rule of thumb for clinically meaningful weight loss, It has recently shifted to 10% because of the diabetes prevention program showing that it takes about 10% sustained weight loss to have prevention of cardiovascular events. But that's been a moving target. Unfortunately, about 80% of weight that's lost is regained fully by 5 years. Bariatric surgery is a different story. It's not perfect, and it sure is expensive, but 90% of people who undergo bariatric surgery maintain 50% of their weight loss. So that is one way to achieve maintenance. Our gold standard behavioral treatments involve what we call intensive lifestyle treatment. It is restricting calorie intake by tracking what you're eating, increasing your physical activity, and learning behavior change techniques. The diabetes prevention program was a very important, large study, more than 3,000 people all over the US. Similar studies, very similar, have been done all over the world and with basically the same results. People were randomized to one of 3 treatments. The intensive lifestyle treatment was what I've described to you. It was individual, intensive, an hour of treatment every week for 6 months, and then every other week going out to a year. The comparison condition, which everyone thought, that at least the medical community thought would be the winner here, was metformin. And by the way, I should say that everyone who enrolled in this study had prediabetes, and metformin is your drug of choice for that condition. Or they got a placebo. The study went on for between 4 and 5 years, and then it ended and there was a transition, but most of the patients were followed, or were at least given the option to be followed. And they all got now quarterly lifestyle classes. The metformin group continued to get their metformin. The lifestyle group had a couple of booster classes per year. And there are now some quite long-term follow-up data. And here you see them for men and for women. The first thing that just blew everyone away is that if you look at the results out to a year, which was how long the intensive treatment went, what you can see is that that dotted line that is showing the most weight loss was not metformin. It was intensive lifestyle. It was the behavioral treatment. Metformin did better than placebo, but the intensive lifestyle clearly produced more weight loss. However, when we look at about 4 to 5 years, that advantage over metformin is gone. I mean, the good thing is that there is still a benefit compared to placebo. It's not a massive benefit, but it remains clinically significant out to, what are we now, 15, 17 years, and we still have a benefit persisting. But the thing that got us all quite distressed is what's now come to be called the inverted check mark, this big dip and then the losing the benefit, going back up. So we now move to anti-obesity medications. And I have to say, truth in advertising here, this is actually where I began my research on obesity. I've always been interested in multiple health behavior change, multiple risk behaviors, and I was studying quitting smoking and became very conscious that many women in particular are afraid to quit because they're concerned about weight gain. And about 80% of people who quit smoking do gain weight. What we know from the mechanistic studies is about a problem of overeating and heightened craving for sweet snacks lasts about 3 months. So I felt, well, look, 3 months is not all that long. If we had a drug that could both help people maintain their smoking abstinence and not get into the pattern of overeating that causes them weight management problems, that might be worth doing. And I worked on quite a number of different drugs, mostly in the serotonergic serotonin reuptake inhibitors, high-dose Prozac, dexfenfluramine, a serotonin releaser. I kind of saw what happens with a lot of obesity drugs. The most disappointing was the story with dexfenfluramine, which had been marketed very successfully all over the world, and suddenly got FDA approval to be marketed in the US. And all of a sudden, Mayo Clinic, within 3 months, found that it caused heart valve problems because there's a lot of serotonin receptors in the heart. And it was taken off the market, and that was it. And we've had a number of obesity meds since then that either have been taken off the market or just have quite unpleasant side effects. But we now have a new wonder drug, and it really is being treated like a wonder drug. We have liraglutide, and then we have seraglutide. These are glucagon partial receptor agonists. They work by a different mechanism than many of the prior drugs. They have to be injected. Liraglutide had to be injected daily. Seraglutide can be injected weekly. And here are the first results from the trial of liraglutide, which appeared in New England Journal of Medicine. It was done in Scandinavia. And what you see is indeed the combination of exercise and liraglutide produces more weight loss than either exercise alone or the drug alone or placebo. And very nicely, it also hits some of the biomarkers that suggest that we're on a pathway to preventing the kind of metabolic disturbances that we worry about in obesity. So it has benefits on resting heart rate, on HOMA, on HbA1c. Notice also, which I found interesting, this yellow bar at the beginning. This is what happened when people were on the behavioral weight loss treatment for about 2 weeks. They actually showed greater benefits than the drug produced. But we can say that was an early onset benefit. But anyway, so this was very exciting, got a lot of attention, seemed like a new wonder drug. Now, in the US, we're mostly working with semaglutide, and this is what we are starting to see. And this is exactly what I used to see when I worked with weight loss pharmacotherapies. This is a trial in which people were kept on semaglutide, injecting weekly, for more than a year. And you see this wonderful % weight loss. That's pretty extraordinary. Down to about a 16%, 17% weight loss. But look what happens when you take them off the drug. They start regaining. And this is such a common curve. We see it in behavioral weight loss. We see it in pharmacologic weight loss. I used to usually see rebound weight loss when I was working with smokers on medication. They would wind up worse off than if they had been on placebo. So this problem of maintenance has not really been solved by these meds. This is probably the most famous weight loss maintenance trial that we've ever seen. It was done by Mike Perry, who's at University of Florida. And you see in this first part of the graph, this is % weight loss, and they have actually got people down to maybe a 10, a 12% weight loss. That's really unusual. 5 to 7% is much more common. And they also figured out how to maintain weight loss. Take a guess about how they did it. Just place your guess, because I'm going to then unmask what they did. They just kept treating people forever. They kept giving them behavioral weight loss treatment, either individual or group. And you can see that if you keep doing that, at least for another 6 months, you can maintain weight loss. You start to see a bit of an upturn here, but a whole lot better than the inverted check mark that you see with no maintenance therapy. But this is not exactly inexpensive, nor is it unburdensome for people. So this is, yeah, we know how to do it, but not everybody will want to come to either behavioral or drug treatment forever. So I think where this puts us is, and this has become, it's been for a while, but it really has become a major focus of concern for the National Institute of Health, given people's preference for behavioral interventions, given the fact that we now can demonstrably produce behavior change, but we really are pretty terrible still at maintenance. This has become a major priority area. There are several large NIH-wide groups sponsored by Office of Behavioral and Social Science Research that are working on this problem of, okay, how can we get a better handle on maintenance? This is a systematic review of theories that I think is quite good. It's by Kwasniaka. It appeared in Health Psychology Review in 2016. If anybody is interested, this OBSSR group that I've mentioned has done a lit review of the major theories in the area. They've flagged about 12 that they think are really worth paying serious attention to. Most are covered in this table that I have up here, but I'm happy to share those slides and those references with anybody who is interested. And basically, this seems to be what we know about what works for maintenance. They did this qualitatively and culled all of the major themes from models of maintenance. We know that motivation is important, and it's part of the reason why you'll often see motivational interviewing used at the beginning of most behavior change programs. People, they tend to do better if they're satisfied with the behavioral outcome. It's making them feel better. They're getting compliments. If they enjoy engaging in the behavior, this is often a problem for people who are trying to become more physically active. They may be able to get themselves to exercise, but sometimes they don't get to the point where they enjoy it. We start to feel like we're going in a good direction and towards better maintenance if the behavior is congruent with your identity. So if, for example, you start thinking of yourself, if it's weight loss, as a thin person, which is very, very hard to change for many people who've been obese their entire lives. If you become somebody who thinks of yourself as a healthy person, not a smoker, if it matches with your beliefs and values, if you want to be a good role model to your kids, if you want to be around to play with them when they get older, these are the kinds of things that we tend to hear people talk about when they're on a good trajectory towards maintaining a behavior. Besides the motivation, there are certain behavioral things that work, and we have replicated this again and again. These tend to be covered by what we call self-regulation theories. And basically, the most important thing is tracking. If you want to change your behavior, you really need to know what you're doing now and what you're trying to get to. And it really helps if you're tracking your behavior and getting feedback about how far you are from your goal. Those are some of, you've probably heard of the behavior change techniques. Self-monitoring, goal setting, and feedback are three of the most best supported evidence-based treatments. Social support is another one. We'll come to that later. But these are things that work. Self-monitoring is our best predictor of health behavior change and maintenance. And it is the thing that apps excel at. Apps can at least make this convenient. They give you resources to look up your the METs that you're burning with different exercises, the calories that you're taking in from different foods. They can gamify the recording process. They can make it a little bit more fun. It's not fun. It's burdensome, but it works. And so it's a core of almost any weight regulation, weight loss strategy I know. Resources is a third component of most theories. People tend to be better at maintaining their behavior if their psychological and physical resources are plentiful. At a physical level, if you can afford a gym membership, it's more likely that you will be able to exercise. If you live in a place where it's not always snowing or raining, that will help. And then psychological resources, things that consume your momentum, your stamina, are really bad for behavioral maintenance. Fatigue, stress, preoccupation, worry. These are things that basically deplete your reserves, and probably because most of the things that we're doing to try to modify and control our behavior require a lot of executive functioning. They require you to have intact frontal lobes, and they use a lot of working memory. These resource depleting things take away from your core internal resources, and so they get in the way. Habits. This has been a major focus of a lot of research. Habits is a very interesting concept. It actually began in the animal literature. You think about something like Pavlov's dogs, who learned to salivate to the sound of a tone, right, which was paired with seeing a food that was appealing to them. What we are trying to get at when we are trying to build habits is basically to create unconditioned healthy responses. So essentially, we are trying to pair healthy behaviors with cues that trigger them. At a very cognitive level, we talk about this as implementation intentions. You can think about it as when people are trying to establish regular eating habits, they may try to eat at a certain time of day all the time. They may try to exercise stimulus control to get all of the appealing foods that might cue them to want to eat something unhealthy to try to get them out of their house. It's trying to drive the behavior in a cue-driven way because that is automatic. It's not effortful. You don't have to use psychological working memory resources. It's out of your hands. I think the data about how well we can do this are a little bit mixed. I mean, frankly, I think it's a little bit scary if we come to the point where we're totally habit-driven, and often things in our environment do change, and we need deliberative, effortful cognitive processes to cope with novel situations. But the good thing about habits is that they free up wherewithal to use good deliberative decision-making to cope with hard challenges. Last category of theme that appears in many of the theories about maintenance have to do with environmental and social influences. To have a supportive environment, to the extent that you can be out of a toxic food environment, or at least if you can make your house not a toxic food environment. If you can be around people that are supportive of your weight loss efforts, and this is tricky because sometimes the people that you think would be supportive are actually a little bit threatened that you're making these healthy changes, and may feel threatened and competitive. And so it's social support it can be a double-edged sword, but these social and environmental supports help. Okay, so I am now going to shift gears slightly and talk about, I mean, obviously I see smoking and eating, unhealthy eating as rather similar things. I used to study them together, and I see them as having many similar determinants. But I'm going to shift to the example of smoking because I think it illustrates some of the cutting edge work that's being done in digital interventions that really does open exciting new possibilities. most of the treatments that we've seen so far, be they taking a pill at a certain time where at least you've got something circulating in your bloodstream all the time, or behavior change things where you're usually working with a fixed intervention that's trying to teach you skills. It's doing it in a sort of a bolus dose, a fixed sort of a one size fits all. You do it at a certain time and then you're out on your own. The thing that digital treatments enable us to do is they capitalize on the fact that we know that that's not really when behavior problems occur, when you're sitting in your office or sit with the therapist, or you're sitting on the phone with the coach. They occur when you're out and about. They wax and wane. They come and go. They're dynamic. And here I'm going to channel Donna Sprouts-Metz, who many of you have heard in this mHTI previously. But this is my example for smoking. So here we have a nice guy who's recently quit smoking, and he's doing fine. He's out on the first day quitting smoking, and he runs into a buddy who he likes, and the guy doesn't smoke, and he feels good. His cravings are low. They're down at the bottom here near the floor. Then he runs into somebody who is a smoker, who he has hung out with, who he's presenting all the cues that are a problem for this person. And his craving now, it's cue driven, it's on the ceiling. And then he manages somehow to get out of that contact, and he goes for a walk. And now he is out in a situation where, he has no prior history of smoking in beautiful natural surroundings. His craving is not being triggered. It's down, his cravings are down at the bottom. So when do you think this guy needs the most help with his cravings? Is it like now when he's walking around calmly surrounded by nature and he's not having cravings? Or was it before, when he was around the guy who was smoking? Or what we'll talk about in a minute is stress. Stress is another major trigger for smoking, for problems with triggering smoking. And my guess, and I would imagine yours would be, well, when he needs help is when he's being triggered, when he's having cravings to smoke. Well, in fact, it's really, really hard to quit smoking. We know that about 93% of unassisted smoking cessation attempts, unmedicated, not in a formal treatment, they fail in the first week. Really tough stuff. And many people say that the problem is stress, that they've been using smoking as a way to manage their stress, and now they don't have anything to do that effectively manages their stress. Now, this is a little bit odd because in the behavioral sciences, we have a whole lot of effective stress management techniques. They're just everywhere. But their track record for smoking cessation has not been very impressive. I suspect it might be because, again, this is fixed static treatment. You come for your sessions with your coach or your interventionist, and then you're out on your own. And the problem of cravings and stress is usually not happening when you're on the phone with your coach or in the office with your therapist, because stress is a dynamic state. And if you're like me, when I get into a stressed state, I forget to use all these great strategies I've learned. The good thing that continuous digital sensing gives us is the ability to detect stress and prompt stress management, as in a JEDI, a just-in-time adaptive intervention. And the other great thing is that some of these interventions now can actually be delivered by an app. So if we can detect when stress is happening, we can prompt somebody very gently to use an app. And this is the trial that this probably has taken 4 or 5 years by now. This is the Sense to Stop trial. Oops. We had folks who were wearing chest and wrist sensors, and they were picking up ECG and, oh gosh, what else? respiration, sending the signals to the smartphone where they were being analyzed. Oh, goodness, come on, bunny. By an algorithm that classified the minutes as stressed or unstressed. The question that we wanted to answer in this study is, when is the best time to open a relaxation app on the person's smartphone to prompt them very gently to practice the strategies that they've learned? I would have guessed it's when they're stressed. But there is another way of thinking about it, which is that, our cognitive functions are not at their best when we're stressed. Maybe we really can't process any more sort of prompts in that state. Maybe it would be better to give us that kind of prompt when we're not stressed. So we're more receptive, we can reflect, we can practice the skills. That's what the study was designed to tell. It was a micro-randomized trial. Here's the protocol. It was a 14-day study. People began in the lab for 4 days. While they were in the lab, we taught them how to wear the sensors, how to use the devices. We trained them on these stress management techniques that the apps were going to introduce them to. They were things like Headspace, mindfulness apps. And we also gave them an intensive quit smoking training on the strategies they could use. Day 4, we sent them out into the wild. We gave them a couple of follow-up brief telephone coaching calls to help them stay smoke-free. And then they were out on their own for 10 days. They came back at the end of it, returned their equipment. They were supposed to do their best to stay smoke-free during this time. And they couldn't have entered the study unless they agreed to quit smoking for at least 48 hours. Here is the design of the micro-randomized trial. So why is it called a micro-randomized trial? I'm sure you either had this or you're going to have a lot more of it, but it's a very cool thing. And it's called micro because we're not randomizing people to one intervention or no intervention or one intervention or a different intervention. In this case, we are randomizing minutes. We are randomizing stressed and non-stressed minutes to receive either an intervention, the opening of the stress management app, or no intervention. And how are we telling if we are on the right track? How are we telling if we have the right answer? Well, their thinking is that if we have the right context to be delivering this intervention, what should happen is that when we open the stress management app, the person should engage in these activities and be able to reduce the odds that they will be stressed again in the next 2 hours. We think of this as they've learned a preventive strategy, and the preventive strategy is working to reduce the triggers to a smoking lapse. So that's what we're looking to see. We call stress our proximal outcome. What we are doing in a micro-randomized trial is trying to figure out the decision rule for a just-in-time adaptive intervention. You can think of this as the intervention by context rule. What is the right circumstance, the right time, the right internal state to deliver this micro interventions, light touch intervention? I will just note that I'm oversimplifying a little bit. If you look at this blue silo here, we are not actually randomizing every minute. We are only randomizing available minutes. We remove a ton of minutes because the person is driving, it wouldn't be safe. We can't tell for sure if they're stressed or not stressed. For example, we can't really differentiate physical activity from stress, so we take all those minutes out. We haven't bugged them with another intervention in the last hour. They've got enough battery to go ahead, and so forth and so on. So as you can imagine, this is very early stage research. These were new sensors. There's a lot of messiness. It's more a proof of concept than a ready for prime time full clinical trial. And you see it here. We enrolled 75 smokers in this trial. They were between the ages of 18 to 65. They had to have smoked, every day for the past year. and they had to be willing to quit for at least 48 hours without any kind of cessation meds. By the time that we get to the analytic sample, because remember, what we're analyzing is whether the person was stressed in the next 2 hours, we are only able to analyze 65% of the cases because people withdrew, their data were messy, their sensors became detached. We had to do some more work on the app, they participated only in beta testing. And so we have 65 people, but we have a ton of data on those people. We have 4,805 decision points, stressed or unstressed minutes that were eligible for randomization. The other thing you see instantly is there are a whole heck of a lot more not stressed minutes than there are stressed minutes. There are 4,510 not stressed minutes. There are about 15, which is about 15 times the number of stressed minutes. In part, that's because people, fortunately, spend more time not stressed than they do stressed. It's also because we can't differentiate physical activity from stress. So we had to take out all of those ambiguous minutes that might have been physical activity. And the other thing is that after people relapse to smoking, they have a lot less stress. It's true what they say. Their return to smoking does really cut down on their stresses. And here is the result. When people are stressed, they are 51% more likely to experience stress in the next 2 hours if we deliver the stress management prompt compared to if we don't deliver it. If they're not stressed, there's no effect of delivering the prompt. This obviously is not what we had hypothesized, not what we had predicted. There's another interesting thing. If we look at the amount of time that people spent in the study, this adverse effect of prompting people to manage their stress when they are under stress gets worse over time. On day 5 of the trial, they were about 55% more likely to be stressed in the next 2 hours if we prompted them with the stress management prompt compared to not. By the time we got to day 10, they were 132% more likely to be stressed if we prompted them. So we have learned something. We have learned, we often say in behavioral interventions that whatever else we do, we will not produce harm. Well, we found an intervention, a Jedi that produces harm. When recently quit smokers experience stress, prompting them to engage in stress management activities may be harmful rather than beneficial, especially if they're a little bit further out in their quit. I think we can treat this as proof of concept that we can conduct micro-randomized trials, which is frankly a miracle, given how early stage these sensors were. We had to develop new analytics. We needed a trichotomous outcome because we had to take into account physical activity separately. But we can conduct these MRTs, and that will let us get better and better at developing just-in-time adaptive interventions. And we also have lots to learn, which if you're a scientist is happy news. I want to just end by flagging that it really took a village to do this study. This is my highly interdisciplinary village. Many of you will see people that you know there and other people that you'll be hearing from in this course. And a special shout out to Santosh Kumar, who you may hear today even. Santosh is the person who got the U grant that funded this extraordinary interdisciplinary collaboration that involved 15 institutions doing everything from developing the sensors to developing the algorithms, processing the data. It was quite a piece of work. And I am done, actually on time.
Bonnie, terrific, wonderful. I think well, thank you again for allowing yourself to be challenged. So let me open it up to the scholars now.
I'll jump right in because I have
Scholars,
two
this is your
questions.
opportunity to worship at the altar.
So I
Honestly.
love your last study, and I almost wonder if, and I don't know if you said you did this, but if the participants had the option to push their own button, if they, as opposed to being prompted, right? If they could do it themselves, that locus of control, if that would have decreased the anxiety. So not
That
an
is-
expectation sort of thing, but I have this sort of right now resource when I need it. So that was just a thought as you were talking about that. I thought, oh, would that have made a difference? You know, just having they felt like they had ownership of when they would perceive that they needed, would that have made a difference in their stress? My second question is about something that you mentioned earlier about, I think you said that before you looked at, if I just would pay people for 3 weeks to just adhere, right? Adherence.
Mhm.
But I didn't see the sort of this motivational enhancement sort of treatment in long-term maintenance strategies that you pointed out, and I didn't hear it as an example. Do you think that there's a role for that maybe? Instead of
Absolutely.
financially incentivizing participants or, to engage after the maintenance phase?
We have to try everything because this is such a big problem and we're not good at it. And there fortunately is a growing literature. The financial incentives is one. There's medical journals have tremendous pushback to financial incentives. One thing that's interesting is this has become an accepted best practice, particularly in substance use, contingency management. We think it's worthwhile to pay people to be drug-free because we don't know how to get them there otherwise. So we accept that. That was pretty radical. But the other question that you raise about motivational enhancement, motivational interviewing, it's almost standard practice in any behavioral intervention. And even in for example, the substance use interventions that use contingency management, there is a magnificent study that Dave Gustafson, who's an engineer from Wisconsin, did. Do you know the study?
Yes, and the app.
Yeah, okay. Gustafson, he's just an ingenious guy, and he was working with very hardcore addicts, and they had them wired up with all kinds of sensors, and they knew their history, and they knew the places that they used to buy, and they were tracking them all the time. And he shows an example of someone who, it was late. He should have been home by this time, but he's on a bus and he's going past the park where he used to buy. And there is a series of safety protocols that starts. First, he gets a text message. How you doing? You need any help? He ignores the text message. Then he gets a call from the therapist. He ignores the call. Finally, the last thing that is rolled out is a video of him when he was using, talking about how awful it is to be in that state and how if he ever gets out of this, he never wants to be back there again. It's like it gives you chills. And we use this, we use it all. And I will say that in a study we've just finished, I was very surprised to see, back to your other point about autonomous motivation, I was very surprised to see that in a weight loss trial, an increase in autonomous motivation that people got when they were coached didn't get when they were just using an app. It explained as much of, it mediated as much of the treatment difference as did self-monitoring. That's potent. That's really potent. I was very surprised. You asked another question first, and I have now forgotten it. I'm sorry.
No, I think you addressed it. Because working in the substance use space, I was just surprised not to see it, right? Like in that table. And
it's motives. It's under, and so the motive about healthy self, about that is where it appears. It's the first thing in the list.
Oh, okay. I missed it then. Thank you so much.
Yeah.
Great presentation. Thank you.
Thanks.